Thank you so much for making the time to be here. My name is Kei Ouchi, and I am moderating this session today. And I'm really excited to hear about how people are actually innovating and using AI in geriatric emergency medicine. Yay! Because we all like aging research and clinical innovations in aging. And we hope that this will be as much fun for you as for me. So I get the pleasure of introducing our speakers today. And I am planning this because I don't know much about this area and I am really interested, so I hope others are too. Oh, by the way, I'm the AGEM Accounting for Geriatric Emergency Medicine president this year, and I'm an emergency physician at the Brigham and Women's in Boston, Massachusetts, and I am a palliative care researcher. So I will start by just people on order of my screen. So Dr. Martha Rowe is from the Department of Emergency Medicine in Emory. And as I learn a little bit more about the speakers, Dr. Rowe utilizes natural language processing algorithms to analyze how medical education materials represent clinical vignette demographics. And she has done more work on this as well as others in this area. And her research also encompasses trying to understand more about disparities seen in clinical care and other undiagnosed diseases and cardiovascular disease in women. And I'm sure I am missing a lot of different things, and I'm looking forward to hearing more about Dr. Rowe's work. Our second speaker, or actually, I'm not introducing them in order, but another speaker is Dr. Andrew Taylor. Dr. Taylor is professor of emergency medicine and vice chair of research and innovation at University of Virginia, where I think he recently moved to. And he's a clinical informatics specialist who was previously at Yale. And I read an impressive list of research studies and grants, but some of the areas where he focused areas that he focused include machine learning and predictive analytics, data mining, and discovery of optimal pathways of care through use of decision analysis. And the topic that I'm more interested in is EHR-driven outcomes-based research. And I'm really curious how he has been sort of developing his AI expertise in all of these different areas and more. And I'm looking forward to hearing more about that, especially applying to older adults. And our last but third speaker is Dr. Adrian Haimovich. Dr. Haimovich is at Beth Israel Deaconess Medical Center in Boston, Massachusetts, right next to my window here. But I never see him in Boston. And I know him the most because he has been really stimulating me in work of using data as well as electronic health records to figure out how to deliver better care for older adults, especially when they are approaching near the end of life, which is the topic that I like the most. And he definitely always motivates me to figure out what can we do better in using the emergency department visit for older folks using data and things that we don't have to do every day as physicians. Like, if we're asked to do one more thing on a shift, we can't do it, even though we love to do it. And how can we make the system make that work for us? So, really enthusiastic about this talk. And so, Dr. Howard, please.
Thanks for the very warm intro, and it's nice to see so many friendly faces here today. Okay, perfect.
Oh, and the reason why some people's names are my name is because I must have screwed up the Zoom link. I apologize, but if you want to stay as my name, that's fine. It doesn't really matter. So thank you so much for being here.
Oh, yes, I was wondering how you managed to split your personality into so many fractions, Kay. So today I'm going to be talking about my work at the intersection of clinical decision support and serious illness communication in the ED. And as Kay mentioned, I'm at Beth Israel Deaconess in Boston. My conflicts, I have no conflicts. I'm really excited that this work is now being funded by an NIA K-23 and was previously supported by GEAR. And then I was previously on a K-12, which also supported parts of this work. So this is my favorite slide of the whole thing. So I'll introduce my work with this sort of overarching hypothesis or overarching perspective, which is, I think, like kind of depressing. And it's that our ER patients like need a lot more support. They need a lot more care. And unfortunately, going along with that is that like no one has bandwidth to do more caring. There's just no capacity left in emergency departments to do more support. than the things that we're already doing. And so the way I think about this world is whether or not, or to what degree, or in what ways AI can help with that. And maybe as evidence or as sort of like the start of a laundry list of things we're told to care about, it's like here are, I think, about a dozen or so things, or maybe 14 things that like these were the first 30 seconds of things that I thought about this week that people told me I had to care about as it relates to my AD care. I've been told I have to care about safe, high quality care. I've been to resident teaching, sepsis compliance, pain control, our door to doc times, our left without being seen rates, our mental health screening, our doctor dispo time, our safe discharge planning purposes, our bounce backs, our restraint orders, our opiate prescribing, our billing and coding, our social determinants of health. Are we having fun? I don't think we are. So all this is to say that like there's lots of things that we're being told that we have to care about every single day. And then if you spend time in the Asian community, you know that there's several more things that we're supposed to care about that very few other people care about. And that are things like delirium and falls and cognitive impairment screening and frailty and vision and sensory screening and nutrition screening and social needs screening and polypharmacy screening. Just like it's crazy. It's crazy how much we're being expected to do. And yet I think we all agree that these are things that it would be good to do. So the way I think about this is that, maybe you're at some place that's really special and you've hired like a one FTE geriatric case manager, geriatric nurse to be able to help with this. Or maybe you're like someplace really special and you have two NED physical therapists who can help with some of these assessments. Or more likely than either of these, you just like have a physician, like a Kei Uichi of the world, who just like cares an enormous amount and does a lot through their own grit and hustle. But most likely of all, you have nothing. You have no support, and no one is doing anything about any of these topics. And so, one of the reasons you're here today is to try to learn more on how to bring it to your department. So all this is to say, there's so much we're being asked to do, and we're receiving so little support to do it. My particular area of interest is in palliative care slash end of life needs screening. And there's a couple reasons that I care about this specifically, but I think of this problem as a microcosm of, or sort of a parallel to any of the other types of problems that I've already mentioned. And I care about it because I think we see it when the writing is on the wall for our older adults. We see patients who are kind of going through the revolving door of hospitalizations on their way to dying. And so oftentimes we look at that and we think, well, this isn't going very well. We also see these like really critical inflection points where people who have like previously stable disease are now like really with unstable disease. Their CML became AML or whatever it is. And I think maybe most pertinently for me personally is that I see suffering when the process of palliative and end of life screening has failed. That is to say, we are asked to have the crisis conversations of like CPR, no CPR, intubate, no intubate, central line, no central line, etc., with patients whose crises were predictable and should have been addressed earlier. And so, and that's associated with our distress and also the distress of patients and caregivers. So for all these reasons, I think that this is a really important problem. And the solution to sort of what we're supposed to do with patients who are approaching the end of life, and this is not what we're going to spend a lot of time on today, but just to say that this is the way I think that the world is supposed to be doing this, is with like lots of little conversations, in a way that I think of as like iterative communication. So in iterative communication, and I think one of the current like sort of branding or frameworks for this is called serious illness communication. You're supposed to have lots of little conversations or lots of medium-length conversations with a couple different providers over time, where you are using these conversations to understand the patient's hopes and worries and understand prognostic knowledge, to build prognostic awareness and resiliency, and then ultimately, hopefully, impact their quality of life. And I think that the serious illness communication sort of works by two mechanisms. And one mechanism is that it prepares the patient and their surrogates to both for decision making and for advocacy so that they can say what they want to have happen for themselves. And the second way that it really matters is that it modulates what our health system sees. So we now, it basically makes a medical record where there's documentation and health system awareness of what the patient is looking for and what has been said to the patient previously. And we know as ER doctors, that's really important stuff. So what I'm going to be talking today is thinking about how we go about finding patients with palliative care needs. And then, hopefully in a future version of this talk, we'll be talking about what the best things we should be doing for these patients is. So one of the sort of canonical ways or sort of most commonly used ways for finding patients who will benefit from some end-of-life conversation or serious illness communication type discussion is with something called the surprise question. And the surprise question is, would you be surprised if this patient died in the next 6 months? And there are sort of major problems with that. The surprise question is binary because you're either surprised or you're not. The performance is mediocre, as sort of shown in the in the meta-analysis at right, which is the surprise question from a number of different studies. And it's also just annoying. It's annoying to be asked of all these different patients that we see, during some part of our workflow, if the surprise question of the patient. And this is a screenshot below for those of you on Epic. This is a screenshot of how it might look in your order set when you're trying to admit the patient. You're just trying to get the patient in the hospital, and then you have a click box that you have to go through. It's not what you're thinking about. It's not what you're doing. You're just trying to move this patient along. You don't want to engage in this. It's just annoying. And so the answer you're going to put is yes, I would be surprised because you don't want to have to deal with the outcomes of the question. So you may recognize the photo at top right here because he's another one of the speakers today. But when I was a resident, we began to tackle this question, myself, Andrew, and Eula, and now at NYU, and we decided that trying to step away from the surprise question, we were going to think about doing this with sort of an AI model. In this case, it's a relatively simple AI model, something that uses logistic regression. And so what we did is we made a 5-year retrospective observational cohort from the 9 EDs in our health system, and we made a predictive model of 6-month mortality from the ED visit. And what we came up with was 18 variables, which I won't show here, but is available in the paper, that outperformed current models, things like Charlson and Elix-Hauser, which you may know from health services research applications. And what I think was interesting about the study was two things. The first thing was that, as shown in panel C, most of our patients are not that sick. It's a long right tail. Most patients are doing relatively well. So for most patients, like screening is probably not necessary. And the second thing that I think was interesting from this study is that we went to show that patients with high mortality risk had high care need gaps. So the x-axis in all of these graphs is the per patient mortality risk from the JEST model that I described on the prior slide. And the y-axis are various things that I think are reasonable markers of sort of serious illness or advanced care planning quality. And the first is like, has an advanced care planning documentation available in the electronic health record? So of the patients who were 60, let's say greater than 60% mortality risk, still only like 6 or 7% had some form of ACP in the electronic health record. Many patients, up to 80% of patients, had some sort of code status documentation in the ER, mostly because these patients had been through the hospital before, if they're that sick. But then when you look when you look to see their code statuses, even the patients who were, 80 to 100% mortality risk over the next 6 months, like 75% of them were still full code. So to me, this was a clear sort of benchmark that this is a population that we're finding that has clear needs gaps. The next thing we did was we took this out of the derivation health system, and we externally validated it at my current institution, Beth Israel Deaconess Medical Center. And this is a single site external validation study where we had 82,000 encounters by 4,500 different individuals. And what makes this interesting from a sort of AI and technology perspective is that every time you go from one population to a new population, you expose the model to all sorts of opportunities to make mistakes. But then also, when you move from one EHR to a new the EHR, there's a different structure. It's a different sort of environment, and you just don't know what you're going to get. So when we found that the model did really well in this new cohort, it was very exciting and reassuring to us. And in this study, we compared the JEST model to serious illness diagnoses. And this became interesting to me because health systems that are doing sort of aggressive, sort of palliative and stuff like that interventions that are not using the surprise question are probably using these diagnosis codes. These are things like metastatic cancer and ESRD on dialysis and so on. So what we found is that, again, JEST offered both more sensitivity and more specificity than these diagnosis codes. So with a model in hand, and I think it's fair to say that we have that model in hand, the question becomes, how do you implement it? And there's, I think, two different ways that you can think about implementing a clinical decision support AI algorithm like this one. And this sort of is a little bit of a cognitive dichotomy to explore. The first is thinking about it as an adversarial task or a head-to-head task. And I think that in the emergency medicine literature, this is what we see most often. And the sentence that in the paper reads something like this: the human or physician AUC was X and the AI AUC was Y. And then they say, oh, if it's Annals of Emergency Medicine, it says, well, look, the AI wasn't that smart. AI, like our doctors really are better because that's the type of articles that we sort of tend to see. But really, I think that sort of comparison framework makes sense when you're doing something that the human wants to do. For example, sepsis screening. We think about sepsis, it's front of mind, right? We are thinking about if someone is infected. It's what we do. So bringing in an AI algorithm to do what we do already seems sort of superfluous. And I think an adversarial framework makes sense. Like before you put something else on top of the doctors, make sure it's better than the doctors if the doctors are already doing it. The other way to think about this is, however, sort of a collaborative or hand-in-hand framework, where what we're asking is how much human effort can we save because this is something that humans are not already doing. So this is to say you have a task that is going to be something adjacent to the existing human workflow. For example, you want to implement a new social determinants of health screener, or you want to implement, in this case, a palliative care needs screener. This is something that you're not already doing, and so you're bringing in sort of an augmenting technology that might save human effort. So when we look at jest versus the surprise question, where the surprise question is representing the clinician judgment and jest is sort of our AI benchmark, when you hold up the AI versus physician judgment, you see what you would expect, which is that physician judgment varies. Some people are really good at predicting mortality risk, and others are less good. Sort of on average, the jest is better than the average doctor, at least in this prospective study that we've wrapped up. What you also notice is that when you make the physician's involvement not mandatory, that is to say, when you make it a soft stop in the electronic health record instead of a hard stop, people don't really want to answer the question all that much. So our response rate is only 38%. And when you dig into that, it's not, and you look to say, for a given patient, what determined whether or not they got a response in our study? It has nothing to do with who the patient was and everything to do with who the doctor is. Some doctors just feel like participating in stuff and complete all the things that they're asked to do in the EHR, and others don't. And that's okay. But that's the real world. That's what you get when you implement something in the electronic health record. You get some people who participate and some people who don't. So what I think is most exciting about this is that what we then looked into is this sort of collaborative framework where we said, what percentage of patients are sufficiently low risk by jest that asking the doctor couldn't possibly change the mortality risk cutoff such that it's not even worth asking. That is to say, for what percentage of patients do we not have to even ask the doctor because we're so confident with jest that they are either low or high risk? And depending on the mortality risk threshold that you use, and I will direct you to the third bar, the third sort of horizontal graph down, you can eliminate like 92% of screening. So if you say that, we want to find everyone who's, let's say, greater than 30% mortality risk, because that's the cohort that we want to get our palliative care intervention, then, and if you pre-screen that population with jest, you are left with only about 8% of patients who need the physician to weigh in to be the tiebreaker because their jest score is somewhere in the middle. So for me, this has like a real potential value across all these different types of ED need screening. So if you're going to do fall screening, if you're going to do, cognitive impairment screening, this is the way to do it, where you basically pre-screen with some AI model to dramatically reduce the effort and the number of patients that you need to intervene upon. So thank you. And I'll give you sort of my brief summary. And that brief summary is that emergency medicine requires an enormous amount of caring. And I'm deeply skeptical that anyone has more caring to give. One thing that requires a lot more caring in the emergency room is patients with their intensive end of life needs. And I think the surprise question is a fine way to go about it, but it's hard to get doctors to do that. AI probably does at least as good a job as the surprise question. That is to say, AI probably is as good as humans at this, and probably for most patients can save the physician effort. So hopefully by the next time I'll talk to this audience, I'll have some interventions to describe to you. Thanks very much.
Thank you so much, Dr. Hybrovich, for taking us through your thinking process of how you asked a question and develop a system to answer and retested the system, and always thinking about why AI might help us and how. So that's really interesting. Thank you for sharing that. I think we'll save all the questions until the end, and we will move to our second speaker.
Thank you so much, everyone, for being here. We're shifting gears and basically going to talk a little bit now about how to develop those caring EM docs that you want to work with in your department, because we're going to look at AI use in medical education. So for disclosures, part of this work is funded by an SAEM Foundation education grant for this year. They're fantastic and thank them. I thank them very much. So I'll be talking about 3 different projects. The first one is the funded project, and I'll go through each of the 3 to basically look at the different spaces within MedEd where AI can and should be used. So first, I'll talk about using NLP algorithms to investigate representation in clinical vignettes. So we'll start with a little thought process, and I only have 15 to 20 minutes here. So you'll be thinking quickly during this presentation. So think about the last time someone in the department was asked to write a clinical vignette. It sort of goes down the line, and whoever's holding the hot potato at the end is the one who starts writing the educational materials. So when we write clinical vignettes, they're individually created by different lecturers that have a prompt they're going for. Maybe they want to talk about trauma, or maybe they want to talk about myocardial infarction, and they're siloed into their one presentation. So in order to review clinical vignettes, previously the way this has been done, and it's been done at a variety of institutions, even back into the late 90s was the first paper that I saw on this. This work was completed by a group of us at CU School of Medicine in Colorado. And what we basically did was looked at 144 clinical vignettes from our cardiology curriculum. And we asked, what is the total representation of different populations in that curriculum? So we had a standardized code book. Anytime that there was discrepancies, the reviewers met to discuss. And the question we asked was, who is missing from our clinical vignettes? Who are we describing? And then by looking at who we're describing, who is missing? And what we found when we looked particularly at the MI cases, and I promise this will get back to older adults, when we looked at the myocardial cases, we found that 75% of those clinical vignettes represented male patients, that all of the patients that ended up with a diagnosis of myocardial infarction presented with a chief complaint of chest pain, and that in the female cases, 0 of the cases describing women were of a STEMI, and 0 of them received PCI. So what we found is that some of the healthcare disparities that we see in patients were actually represented in our clinical vignettes, in our educational materials. So we know that women are underdiagnosed. We know that women often don't present with chest pain as a chief complaint. And we found those discrepancies mirrored in our clinical vignettes. However, you're only able to see those discrepancies if you look at the total cases that are being presented. So basically, you have to ask, what is the total exposure that a medical student is getting to clinical vignettes in cardiology, for example? Most evaluations of bias in the curriculum look at individual clinical vignettes. How do you describe someone with substance use disorder in this one clinical vignette? But it's very difficult to look at underrepresentation because it only becomes apparent when you look at the entire curriculum. So manual review, I'm sure that this group is not interested in manual anything, but to be clear, it's slow, labor intensive, and it's not scalable. So I hope that I've convinced you that how we present clinical vignettes matters, and we're really only able to evaluate that when we can look at the entirety of the curriculum. So the next steps is developing an NLP algorithm that can actually take large volumes of curricular material and give us that information. So we've started this process using a Lambda 3 chain of thought prompting large language model, and we've gotten to a point of an FI score of 0.72 for demographic data. And this includes things like age, sex, past medical history. We have looked at stigmatized behaviors such as substance use disorder and homelessness, insurance access, healthcare access. We've looked at a variety of demographic data related to training this algorithm. We've evaluated it using the manual clinical vignette annotated data set that we created with the cardiology curriculum. and it's starting to represent pretty close to what humans are able to get to. I was very surprised at the amount of inter-rater lack of reliability, in that many of us would miss different clinical vignettes when we were reviewing cases. Many of us would miss different demographic information when we were reviewing. We all thought, as we talked about sort of the average physician, that we would be above average and all find everything. Turns out that we didn't, and we're able to get this algorithm pretty close to what we can do. So to be clear, the NLP algorithm does not evaluate for bias. You have to be very specific in what you're asking it to look for, and it doesn't come up with those ideas or concepts on its own. And so when I talk to a lot of educators, I have to be very clear that you can't ask the algorithm to look for bias. There is no bias detection button. So we have to decide what to review. And so far, we've looked at women in myocardial infarction, which is what I presented here, sort of what disparities are perpetuated by lack of representation, what stereotypes are being reinforced. So we looked at description of Black men and violence. So there were cases that described Black men in correctional scenarios that didn't require that description, and we didn't see the same correlation when we looked at white men or males without a description of race. And we've also looked at which groups are presented with what we call without sufficient context or complexity. And so are we describing certain populations only in relation to certain behaviors? Are we describing certain populations only in relation to certain risk factors? And again, this is basically to show you will only find the data that you're asking it to look for. All right, so that's the first project that we've been working on, and that's been going on for a little while. And I feel like much as was talked about in the next presentation will hopefully be on the dissemination of that algorithm so it can be used. It can be used in multiple schools. The next project I want to talk about is the use of AI to evaluate ageism in clinical conversations. So as we did this didactic work more and more, I see Hive rising. There you are. Love it. One of the discussions that we had is how important those clinical scenarios are and those clinical experiences. So it doesn't matter what you present in your clinical vignettes. Once those students go on to the wards, whatever experiences they have there are more powerful than what was represented in their didactic curriculum. And so we have to also address ageism in that context. And so I'll give a little bit of a background here. This is from a different presentation that I gave regarding medical transcription technology. And so currently we use ambient AI as a scribe, right? That listens to our conversations, it creates a transcript and creates a clinical note. And there are a variety of groups that are working on this. And we said, what if we use this to actually look at our students, at our learners? So I'm giving an example here. This is a real example. There was a trauma activation for an auto versus bicycle. There was a bunch of commotion. I walked into the trauma bay with a medical student, and we were able to see from the foot of bed that it looked like a male appearing patient wearing Lycra, like a racing suit, still with their bicycle pedal click shoes on. As people started to move out of the way, as his helmet was removed, it became clear that the patient had sparse white hair and facial features consistent with being an older individual. And without any prompting, the student beside me said, OMG, what is he even doing on a bicycle? And so a lot of us have been in clinical scenarios where we are forced to address with medical learners what implicit assumptions are present in what they're speaking about. But it's very difficult to respond to that in addition to being intimately involved in the patient care, right? So I think with an unlimited amount of time, you'd be able to turn to that student and say, well, let's talk about what you just said there. What are you assuming about this patient, about their abilities and their inabilities and their activities of daily living and what they should be doing? What do you think about injury risk assessment in this population? But when you're standing in the trauma bay and you're dealing with a patient in front of you, don't always have the opportunity to have those discussions with students. And so many of us have felt what we say in the initial moment would be very different if we had the opportunity to circle back and really show the learner what they said, right? We can use ambient AI in these situations to actually pull up a transcript of what was said at the time and actually show the student what they said at the time and how we could maybe reevaluate that separate from the clinical encounter. And we've started to use these in the setting of medical learners where they will record conversations that they have with students that can be evaluated after the fact. So it takes away that pressure of students being felt like they're being watched immediately and they're going to get immediate feedback in a clinical scenario, but we have set times where we can then review those transcripts and we're able to, in a less pressured situation, be able to discuss how those clinical scenarios went. And then the third project that we have ongoing related to AI is evaluation of age-based treatment recommendations by AI chatbots. And I'll talk about this very briefly. I'm sure everyone here maybe uses open evidence or other types of AI chatbots to discuss clinical scenarios. Our learners are using these more than you think they are. I think they use them all the time and they use them more than that. It's one thing to be an attending physician and to use these as resources, and it's another thing to integrate these into your learning from the very beginning. All right, and so this is actually an example of how we are integrating this into how we are finding this is being integrated into our clinical care. So I used open evidence and asked them about different scenarios. How would I treat hypertension? How would I treat DCIS? What do you think about a patient with this diagnosis? And then I ask, what if the patient is 78 years old? I'll start with the younger patient, then I ask. And open evidence, if you've ever used it, has a reference for absolutely everything it says. But this was the second sentence after this question with no reference that was given to one of these prompts. Older adults often benefit from less aggressive management, period. And so I think we have to be very cognizant of what sort of impression these are giving learners and what sort of feedback they're getting from these AI chatbots, even something like open evidence, which people feel relatively confident in using because of where it's coming from, that this is not necessarily a false statement. This could be a true statement in a variety of clinical settings, but this is also a loaded statement and may not be applicable to every clinical setting. And students are not necessarily able to interpret this in a nuanced fashion. So we're having more discussions of AI chatbot prompting and how to interpret those results. So AI technologies can and should be used to evaluate bias in medical education. Representation of older adults in clinical vignettes can shape learner perceptions of this patient population and bias clinical judgment. Ambient AI transcription can support structured review of clinician-patient conversations. And then as learners increasingly consult AI chatbots for treatment recommendations, we need to have an understanding of what age-related guidance is being given so that we can address it in real time during the wards. Thank you, everyone. And I heard that we'll be waiting for questions.
Hopefully, we'll have questions time at the end. But thank you so much, Dr. Rowe. And I can't imagine how people are using open evidence if you haven't really practiced medicine for a while. It's wild. So thank you. Dr. Taylor, please.
Awesome. Okay. Yeah. And hopefully I'll be quick so we can have some questions at the end, because I think that's always the interesting part of these talks. I'm going to talk about two things kind of in the geriatric space, but I think they have also general applicability to other areas as well. So the first area I'm going to talk about is urinary tract infections and clinical decision support around that. I think probably most of us recognize this is a big problem. 1 in 12 hospitalizations are for UTIs. There's lots of deaths. We spend a lot of money on it. The workup is actually fairly expensive. If you've ever asked your laboratory medicine guys about like how much effort goes into following up urine cultures and all of the process around that. It tends to be very expensive. And I think, and to Adrian's point, there are probably opportunities here for AI to kind of take away some of that by cutting down the number of urine cultures and things that we do. The other thing you probably know from all of this is that, really UTI diagnosis is a three-step process. So, patients need to have signs and symptoms of urinary tract infection. That's particularly problematic in the geriatric space where they often come in with atypical symptoms, fatigue, just generally feeling unwell, altered mental status, and things like that. And then, the next step along that process is ordering a urinalysis, and then that usually will either get reflexed to a urine culture or it'll be just automated within that process. But I think we all know getting it right matters. So, there's particular harms of overdiagnosis. You can think about antibiotic side effects and resistance and cost. All of those, I think, are even more pertinent in the geriatric space than probably in the general medicine space. And then there are harms of underdiagnosis, including ongoing symptoms. And I think the things that we worry about is like sepsis, return visits, and so on. So this has been a problem I've been working on for quite some time. I think it was probably the first like machine learning model kind of area that I started to explore. And initially approached it as like a general problem, I think, for all of the adult emergency department space. I think increasingly over the last couple of years, we've started to think about this in a more targeted approach. And just, these are just kind of standard diagrams that you will see from a performance standpoint. It's really just meant to demonstrate that, on a general population level, you can get highly performant AI algorithms for this. This is an XGBoost model for anybody that's kind of in the AI space, but generally high overall kind of accuracy in these domains. But really what I wanted to focus on was the right-hand figure. So this is a comparison of diagnostic performance across demographic groups. One of the nice things about having a really large data set to examine this in a fairly prevalent condition is that you can break groups down into intersectional performances and look at models in that way. And I think if you look at the very top, so this is primarily kind of organized by performance comparison between the model and physicians. You can see that there's a big difference between generally kind of geriatric intersectional groups and the false negative rates and physicians. And there's it's a little unclear exactly why this is occurring in this space, but I think it really opens the opportunity for AI models for this particular subgroup of patients to be helpful. And the alternative that I usually frame this in is like, for a 35-year-old female that comes in with urinary symptoms and so on, you probably don't need an AI model for that. And so I think, the time has come probably for just showing this for some patients and not all patients in these different scenarios. And so where are we going with this? So we've been developing out a clinical decision support tool. This uses FHIR, if you're aware of that kind of environment on the back end, to do this real time and to display probabilities and the general confidence levels and the features that are going into this. And then we are actively, actually, this is sort of because of my split from Yale and coming to UVA. So we're actively putting this in on the Yale side and in the UVA side at the same time. That's all been a general population, but we're particularly going to look at it in these different subpopulations. Okay, so I will then switch gears and talk a little bit about dementia in the ED. This is, again, I am not a geriatrician, so you all know this space a lot better than me, but so I probably don't have to go through any of these bullet points here. But I think we all recognize that it is under-recognized in the emergency department space. That under-recognition has a lot of downstream consequences. The example I think that you often gives is there was a patient, seen in the emergency department, and it was discharged home after coming in for like spraining their ankle or something like that, and then they were picked up 4 hours later because they were found wandering the streets and didn't know where they were. And so those are the type of events we're hoping to avoid. And a lot of that kind of under recognition is honestly really like a coding issue. Like people are failing to put in diagnostic codes around dementia, or those are failing to surface up on the front in people's problem list and other things in that space. And then I think there's more under recognition that happens in other areas as well. But one of the things that we were trying to solve is, can we bring up these kind of surface level components that are probably present in the EHR? The other thing to know is that, and this is some data that you had done in the VA that shows that, for patients that are eventually diagnosed with dementia tend to have this kind of surge in emergency department visits that's at 6 months to 12 months prior to that diagnosis. And you can think about, they've had increased falls and other things. So it just reflects a real opportunity to kind of try to address or at least get patients plugged in when they're seen in the emergency department. So, what was kind of our hope and solution for this is one was just to develop some AI algorithm to be able to detect dementia risk for ED patients and then start to think about integration of that risk AI algorithm into the emergency department space. And I think that second part is really complicated because I think when you start to think about how do you present that information, what are you planning to do secondarily to that, it becomes, I think, a really challenging and it's an area of significant research. But I think we all recognize that if you can do this, there's the opportunity to help do early engagement with caregivers, do timely referral to social services, to increase outpatient referrals from the emergency department. So maybe increasing a little bit the burden that Adrian talks about in the emergency department for these patients as far as like what we're doing for them, but hopefully, honestly, moving or shifting some of that kind of burden and follow-up into the outpatient world. So, this is a standard kind of development. We did most of this work at Yale. There was a large training set. We looked at several different types of models in this space. So one of the tricky parts is about how do you come up with a gold standard label that you can train the model on. And so one of the ways that you can do this is through like a semi-labeled approach where you can kind of look at the labeling space of people who have dementia codes and those that don't and approach it that way. So we explored some of those. We explored using traditional kind of ICD code definitions for dementia and building out the model in that way. And these are, again, some of the kind of typical figures you would see. I think the thing to really point out, and this is kind of one of the areas where I was mentioning about the kind of future research. If you look at the predicted dementia probability thresholds on the top left, I think figuring out when and when you fire these algorithms and what that looks like is particularly tricky, and kind of what sensitivity and specificity threshold you're willing to accept and how you present that to patients, I think becomes challenging in this domain. And if you see in table 2, if we compare this to known kind of ICD definitions and then for also in comparison to clinician expert adjudication, there's the opportunity to pick up people through the algorithm that are being missed either through ICD codes or were being missed in some other space as compared to the clinical adjudication. And so, I think what we saw, at least in the kind of retrospective aspect of this, was that, the algorithm had this ability to be able to pick up, dementia. There's about 12% of patients that were coming through would have been potentially flagged as having dementia, and 1 in 5 of those had no prior diagnosis. So there is an opportunity to really, I think, identify groups of patients in the emergency department. If you want to, if you're curious about kind of what are the features that are going into this, so the model itself was a combination of like past medical history and medications and a lot of other EHR structured data elements, but those were the kind of the top features. And a lot of them is kind of what you would expect in this space. And I will stop there and just say thank you. And then we can open it up for questions and discussion.
Great. Thank you so much, Dr. Taylor. That is a whole range of things that we covered in a very short amount of time. And I'm sure some people are interested in one topic more than the other. So we want to open up to the group if there are any questions, and I'll be minding the chat. Yes, Dr. Courtney Jones, please.
Hi, everyone. This work is fantastic. As somebody who does a lot of AI and geriatric stuff, when I saw this webinar, I was super excited. I guess my question is more of a philosophical one, and perhaps maybe Dr. Taylor is best suited to answer it, but interested to hear everyone's thoughts about like the potential for AI to do all of this sort of background screening and prediction, and the potential for like alert fatigue, both for providers and for patients, like the risk of like false positives versus identifying cases. And I don't know how we weigh that in the field of emergency medicine, where, it's not like you have a pre-planned visit schedule and all of these things as part of your routine clinic day. So how do we balance that as a specialty, given the amazing potential utility of AI to do these things? Thank you.
Yeah, and honestly, I think that is a problem for like any AI implementation piece. Is really thinking about all of the kind of downstream consequences of that implementation. It's just, not just in the geriatric space. You have to, I think we were trying to figure out whether we were going to put a deterioration index into the emergency department. And then we started looking at it, and there was some questions that arose about whether, one, there was going to be some automation bias that our nurses were really going to just become overly dependent upon the deterioration monitoring that was being provided, and that they weren't going to, they were going to stop actually using their clinical judgment. There was worry about sending too many people to the ICU because of false positives in that sense. But from a health system standpoint, we really had no great way of kind of quantitatively, taking in that kind of broader picture. And honestly, I still don't think we do have a very good way of doing that holistically for a system, because you do have to kind of model all of those downstream things. There are ways to do it computationally, like you can do decision analysis and things like that, but it's very time consuming. You have to, account for all of these downstream things like, oh, the patient, what's the likelihood the patient's going to, have a secondary infection or something like that if I don't do this particular step. And so I think it's challenging. I think those are areas where a lot of additional research needs to be done to figure out kind of how can we optimize these things, because I agree there's a huge potential that we're going to be faced with a lot of alerts coming from these models in various different spaces. But I think back to like what Adrian was talking about, the other thing is to think really hard about whether the model is providing actual advantages for particular patient populations and just turning it on and, in some circumstances and not others. I think we tend to think about these as being deployed like universally across our patient populations, and it may be better to really target the patient populations that we're looking at.
Thank you so much. We all are all totally alarm fatigued, so I don't know how to make that better. Maybe we get a candy every time I answer an alert or something like that. And thank you, Dr. Jones, for the question. Anybody else?
It reminds me of the early sort of sepsis warning systems and how poorly they performed as soon as COVID happened. And we got alerted by every single COVID patient that came in. I don't think we have a clear answer of how to do it. I think we're learning as we deploy them, but it's something that has to be taken into consideration as we do all of it.
I really wish there are such a wide variety of works that everyone's working on, and they all deal with different types of different applications of AI. And I wondered if there's a platform where you guys all share, represent your work in emergency medicine.
Yeah, it gets fragmented, right? So there's like, there's submissions to geriatric journals, and there's some to the kind of academic emergency medicine like journals. And then if you're doing like heavy kind of AI stuff, then you're going to be in a more technical journal. And it is a little unfortunate that it doesn't get compiled or synthesized in an effective way. But maybe that's another thing to turn AI on for, to try to do that.
That's right. You can summarize open evidence for that.
Right.
Any other comments or like follow-up questions?
I'll just add that I think it was Dr. Rowe, the method that you use with the freezing and like getting people's like thoughts in the moment. That's something that we used, and it's called like a SAGOT methodology. It's like situational awareness. We actually like, it came out of aviation, I think, and I think it's so powerful to use that like moment. So I was excited to see that you use that.
And I think there's a lot of opportunity for expanding that in the future. As you can imagine, there's a lot of ethical concerns with how this is used in medical education and what does it mean to commit to be recorded as a student. And so a lot of that is being actively worked on as we're trying to manage how to use the technologies. So it's certainly more to come.
And I bet it'll be video recorded soon compared to just audio. And it'll capture everything else, like all the exams that you're doing or facial expressions that you're making or eye contact. I mean, so more to come for sure. Well, this bring us to the hour is up, and that was so fast. But I want to thank all the speakers for making the time to share their interesting and thought-provoking work. And I want the audience, thank you so much for coming. And I hope we have all the contact information for all the speakers. So please let us know if you want to have a follow-up conversation or contact with any of the speakers. And thank you, SAEM, for hosting this. And thank you so much for all your time.